Good afternoon. Today I would like to introduce you the next pharmacology lecture, drugs acting on gastrointestinal system. Lecture plan: general considerations, drugs that affect appetite, drugs for peptic ulcer and gastroesophageal reflux disease, drugs that affect the excretory function of the pancreas, emetic, antiemetic, prokinetic, and gallstone dissolving drugs, drugs that stimulate the synthesis of bile, hepatoprotectors, drugs for constipation and diarrhea. Let's start from general considerations. The stomach performs the following functions. First, deposition of food and its partial evacuation into the duodenum at such rate that provides complete hydrolysis and absorption of monomers in the following sections of the digestive tract. In the process of filling the food, the stomach can be very substantially stretched without a significant increase in intragastric pressure. So, the volume of an empty stomach of an adult is about 50 milliliters, and at maximum filling it can increase to 3-4 liters, 60-80 times. This property of the stomach is called receptive relaxation. Second, secretion of gastric juice containing the proteolytic enzyme pepsin and hydrochloric acid, through which begins the initial hydrolysis of proteins. Third, further mechanical mixing of food received from the esophagus by swallowing, shredding, spraying, and combination with gastric juice. The result of this process is the formation of chyme. Fourth, biosynthesis of gastromucoprotein called the internal Castle factor, named after the American physician and physiologist William Bosworth Castle, which protects vitamin B12 from the destruction of hydrochloric acid and contributes to its absorption. For some types of stomach ailments, for example chronic gastritis, the inadequate formation of this factor can cause malignant, pernicious anemia in the patient. Fifth, generation of powerful afferent impulse from tactile, temperature and chemoreceptor mucosa, which form the appropriate emotional background, a feeling of satisfaction with a filled stomach and negative emotions associated with empty stomach and known as a sense of hunger. 6. Protecting the digestive tract from pathogenic microorganisms and poor quality food due to the bactericidal action of hydrochloric acid. Digestive effect of gastric juice and regulation of its secretion. Gastric secretion is fast and is approximately 5 to 15 milliliters per hour. In this, the juice of a neutral or weakly alkaline reaction, consisting mainly of water, mucus, and electrolytes, is formed. Gastric juice, which is released in response to food intake, has a strong reaction, pH from 0.8 to 1.5, indicating a high level of hydrochloric acid concentration, which reaches 0.3 to 0.5%. 99% volumetric gastric juice is water, 1% dry residue. It contains pepsin, an enzyme that is formed from pepsinogen under the action of hydrochloric acid, mucin, gastric mucus, an internal factor of the castle, which contributes to the improvement of vitamin B12, as well as ligase, which has a small physiological role. In addition, inactive gastric juice cations, sodium, potassium, magnesium, and anions, dihydrophosphates, and sulfates are released. The key factor in gastric juice is pepsin, a proteolytic enzyme that is formed from pepsinogen by the action of hydrochloric acid due to the disconnection of an inhibitor of polypeptic nature. Pepsin splits proteins into large polypeptides. Amino acids in this case formed relatively little, but large fragments of proteins that have undergone a long period of gastric juice are easier to hydrolyze proteases of juice of the pancreas and the glands of the small intestine. The role of hydrochloric acid in digestion is: launches the process of creating pepsin from its inactive precursor pepsinogen, starts denaturation of proteins, contributing to their digestion, creates an optimum pH for the action of pepsin, performs the function of protecting its bactericidal properties, enhances the motility of the digestive tract. The motor function of the stomach and its regulation. The motor activity of the stomach provides further grinding of the adopted food, its mixing with the gastric juice, the formation of chyme, and the partial evacuation of this chyme in the small intestine. By the function of the three-layer muscular membrane, the stomach produces a variety of forms of mixing movements and peristalsis. In particular, unlike other parts of the digestive tract, the peristalsis of the stomach occurs not only in the direction of the pyloric sphincter, but also in the direction of the cardiac site. The stomach can be easily stretched when eating, up to a volume of 1.5 liters, without a significant increase in intragastric pressure. This is achieved by receptor relaxation, which is regulated by the reflex neurons of the swallowing center, which stimulate neurons of the intermucosal plexus through the vagus nerve. These neurons secrete tissue hormones serotonin and nitric oxide, which directly reduce the tone of smooth muscles. An additional factor of receptive relaxation is the ductility of smooth muscle of the stomach. However, stomach expansion to a volume greater than 1.5 to 2 liters creates receptor stimuli to suppress appetite and increase the secretion and motility of the stomach. The longitudinal stomach muscle layer contains modified interstitial cells of the cajal that spontaneously generate a basic electrical rhythm of the stomach at a frequency of about 3 waves per minute. Stomach emptying is a process that is very connected with digestion in the duodenum. One peristaltic wave from the bottom to the body of the stomach provides pushing through a pyloric sphincter of just 3 milliliters of chyme. This sphincter is tonically contracted and opens only when the peristaltic wave arrives in it. The pyloric section of the stomach has a powerful muscle compared with other parts of the stomach, but a small volume, only about 30 milliliters, and functions as a kind of dynamic filter which passes into the duodenum only liquid chyme without large pieces of food. After closing the sphincter, the peristaltic waves move in the opposite direction, retropulsation, effectively mixing the chyme. And on this picture you can see the 3 physiological substances that promote secretion. Hydrogen potassium ATPase or proton pump can be activated by histamine, acting through H2 receptors, acetylcholine, acting through M1 receptors, and gastrin, one of the gastrin family G34, G17, G14, and pentagastrin peptide. Hydrogen potassium ATPase proton pump. Hydrogen potassium ATPase proton pump, which secretes hydrogen ions in the apical canaliculi of the parietal cells, can be activated by histamine, acetylcholine, and gastrin, acting via their own receptors located on the basolateral membrane of the cells. Out of the 3 physiological secretagogues, histamine, acting through H2 receptors, plays the dominant role, because the other 2, acetylcholine and gastrin, act partly directly and to greater extent indirectly by releasing histamine from paracrine enterochromaffin-like cells called histaminocytes located in the oxyntic glands. H2 receptors. H2 receptors activate hydrogen potassium ATPase by generating CAMP. Muscarinic and gastrin cholecystokinin receptors appear to function through the phospholipase C inositol triphosphate diacylglycerol pathway that mobilizes intracellular calcium. The CMP-mediated proton pump activation also involves calcium. The secretomotor response to gastrin and cholinergic agonists is expressed fully only in the presence of CMP generated by H2 activation. As such, histamine participates in the acid response to gastrin and acetylcholine at more than 1 levels, and H2 antagonists suppress not only histamine but also acetylcholine, pentagastrin, and in fact any gastric acid secretory stimulus. Gastrin is secreted from the antrum in response to rise in antral pH, food constituents, and vagally mediated reflexes involving ganglion cells of the enteric nervous system. The prostaglandinic enteric nervous system neurons elicit gastrin release from gastrin-secreting G cells by elaborating acetylcholine as well as gastrin-releasing peptide. M1 receptors. The dominant muscarinic receptor mediating vagal responses is the M1 subtype. Its localization is on the ganglion cells of the intramural plexuses has been confirmed. The parietal cell's muscarinic receptor is of the M3 subtype, but the subtype of muscarinic receptor on enterochromaffin-like cells has not been defined. Vagus release acetylcholine in close proximity to enterochromaffin-like cells and G cells, but apparently at a distance from the parietal cells. That is why vagal effects are exerted largely indirectly through histamine and gastrin. Prostaglandins. Prostaglandins have been ascribed a cytoprotective role in the gastric mucosa by augmenting mucus and bicarbonate secretion from gastric mucosal epithelial cells, as well as other actions. Soon after secretion, the gastric mucus transforms into an adherent gel-like layer over the mucosa, which traps the secreted hydrocarbonate ions and prevents their neutralization by creating a barrier for the hydrogen ions in the juice. It also shields mucosa from action of pepsin. Prostaglandin E2, produced by gastric mucosa, inhibits acid secretion by opposing CMP generation in parietal cell and gastrin release from antral G cell. The next part of our lecture is drugs that affect appetite. Appetite is an emotional feeling associated with the desire of a person to eat certain foods. Unlike the sense of hunger, the needs of the body in food, usually subjectively unpleasant phenomenon, appetite is based on the need associated with thoughts about the use of food, which should be and is a pleasant sensation. Appetite is enhanced by thoughts about the appearance, smell, taste of food, the situation where it is consumed, and so on. The appearance of appetite is due to the specific effect of hungry blood on the center of hunger, excitation of limbic structures, transparent partition, almond-shaped body, hippocamp, etc., and the cortex of the cerebrum. In the first minutes of eating, appetite increases, especially when the food is desired. This contributes to the activation of the function of the digestive system, increases the secretion of gastric juice, increases the motor activity of the digestive canal, hungry peristalsis, etc. There are three types of appetite disorders: decrease to complete loss, anorexia; increase, sometimes quite sharp, bulimia; and disorder in which is the desire to use inedible substances, chalk, ash, earth, etc. Anorexia. Anorexia is a complete loss of appetite for the objective nutritional needs due to functional or organic disorders of the appetite center at the level of the hypothalamus or higher analyzers in cerebral cortex. Very often, anorexia is accompanied by stroke, tumors, trauma, and inflammation of the brain, as well as organic disorders of the endocrine glands. It is an important symptom of pituitary cachexia and adrenal insufficiency, Addison's disease. Simultaneously with the loss of appetite, the patient complains of weakness, increased fatigue, apathy. Over time, body weight decreases, tissue turgor disappears, subcutaneous fat layer disappears, weight of skeletal muscle decreases, signs of vitamin deficiency appear, etc. Amara or bitters are the herbal remedies that has a bitter taste, used to increase appetite and improve digestion. They contain glycosides, essential oils, alkaloids, etc. Bitters, mechanism of action. Irrigation of the oral cavity with solutions of amara or bitters, once again, before the imaginary food intake, causes more secretion of gastric juice. In the case of the introduction of these substances directly into the stomach through the fistula, the secretory process is not stimulated. Consequently, The effect of bitterness on the secretion of these glands is reflexive. They, irritating the taste receptors of the mucous membrane of the mouth and tongue, reflexively increase the excitability of the center of hunger, which increases the secretion of gastric juice, increase appetite, improve digestion. According to Ivan Petrovich Pavlov, the use of bitterness creates a contrasting feeling of their unpleasant taste on the one hand, and a pleasant sensation of food on the other, which is a condition for the allocation of mental gastric juice due to the stimulation of appetite. The main demand for the positive effects of bitterness on appetite and digestion is to receive them inside with a little water or almost without it. If yes, then not in high amounts, for 20–30 minutes before eating. Using them in dosage forms that mask the bitter taste, as well as the administration into the stomach with a probe or rectum, is ineffective. The bitters taken internally during meals inhibit secretion and stomach motility. Indications for use: hypoacidic and chronic atrophic gastritis, anorexia of neurogenic origin, post-operative surgery. Contraindications: increased gastric secretion, peptic ulcer of the stomach and duodenum, gastroesophageal reflux. And below you can see the representatives, which are plant preparations. Bulimia. Bulimia is a pathologically elevated sensation of hunger, which is sometimes accompanied by weakness and pain in the peritoneum. This condition is sometimes combined with a decrease in the sense of saturation, resulting in the need for excessive amounts of food, polyphagia. Sharp pronounced constant bulimia and polyphagia are observed mainly in organic brain damage or mental illness, less with the hyperinsulinism, in reconvalescence after severe exhaustion infections, etc. Correction of bulimia is carried out with using anorexigenic remedies. These remedies are usually combined with preparations of etiotropic and pathogenetic therapy aimed at eliminating the cause of appetite disturbance and those mechanisms that underlie them. Anorexigenic are the drugs that reduce appetite. They are used in cases of alimentary obesity, which worsens the course of many diseases, leads to metabolic disorders, disorders of the cardiovascular system, liver, etc. The leading method of treating obesity patients is sharp restriction of food with high energy value and increased physical activity, which creates a negative energy balance in the body. However, during such treatment, it usually occurs a severe feeling of hunger, which causes the use of drugs that reduce appetite. Classification of drugs that reduce appetite. First, drugs that affect the catecholaminergic system and stimulate the central nervous system. From derivatives of phenylalkylamine, fepranone, amfepramone tablets 0,025 and dazopimone. From derivatives of isoindole, mazindole, tablets 0,001. Second, drugs affecting the serotoninergic system, derivatives of phenylalkylamine, fenfluramine, capsule 0.06, and phenylpropanolamine. And third, drugs that suppress gastrointestinal lipases, orlistat, 0,12 capsules. Fepranone and dazopimone. Mechanism of action. Stimulate the center of saturation, which causes the inhibition of the center of hunger. In addition, increases excitability of the cerebral cortex, which obviously also contributes the suppression of this center. In patients with obesity, fepranone and dazopimone contribute to a decrease in body weight. Activity is sufficient in the first 8–12 weeks, then gradually decreases. Contraindications: pregnancy, late stages of hypertension, cerebrovascular accident, myocardial infarction, glaucoma, thyrotoxicosis, diseases that are accompanied by increased excitability of the central nervous system and seizures, etc. Side effects: tachycardia, arrhythmias, increased blood pressure, anxiety, sleep disturbance. In the case of prolonged use, addiction and drug dependence develop. So we discussed bitters, which are used in anorexia treatment. We discussed anorexigenic drugs, which are used in cases of bulimia. And now the third group is drugs that enhance the secretion of the gastric glands. Natural and synthetic gastrin and its synthetic analogues, pentagastrin and also histamine. Let's discuss some representatives. Pentagastrin, used as a stimulant for gastric secretion to determine the secretory and acid-forming function of the stomach. Subcutaneously or intramuscularly administered at 6 micrograms kilogram. Side effects: salivation, nausea, short-term decrease in blood pressure, abdominal discomfort. Next one, histamine dihydrochloride. For stimulation of gastric secretion, subcutaneously administered 10 micrograms each kilogram in the form of 0.1% solution. Mechanism of action: histamine excites specific receptors, H1 localized in the smooth muscle of the bronchi, gut, vascular, and H2 in the mucous membrane of the stomach, uterus, heart. As a result, secretion of bronchial, salivary, and gastric glands is increased, bile secretion increases, capillaries expand, arterial pressure decreases, permeability of the capillary wall increases, circulating blood volume decreases. Along with this, the contraction of the smooth muscle of the organs increases, as well as the secretion of glucocorticoids and adrenaline increases. And the last group from drugs that affect appetite is drugs of substitution therapy. Hydrochloric acid, as the main component of gastric juice, creates the necessary acidity for maximum proteolytic action of pepsin. In the stomach, the acid is partially bound to nutrients, is partially neutralized by saliva, gastric mucus, and the contents of duodenum, which can enter the stomach, for example, in cases of achillia. Only the unbound part of the introduced hydrochloric acid creates a certain acidic background of the contents of the stomach. Indications for use, often in combination with pepsin: achillia, hypoacidic states, dyspepsia, hypochromic anemia. Contraindications: hyperacidity, acute gastritis. Side effects: in cases of prolonged administration in large doses, acidosis, softening of enamel of teeth. The next one is proteolytic pepsin. Proteolytic pepsin is the drug of the gastric juice soluble in water and alcohol, obtained from the gastric mucosa of the pigs and mixed with sugar powder. Taken orally 0.2 to 0.5 grams before or during meals in powders or in a medicine, usually in combination with diluted hydrochloric acid. One more natural gastric juice. This is clear, colorless liquid with acidic taste and weak specific odor. Taken orally inside 1–2 tablespoons while eating. Indications: acute and chronic hypoacidic gastritis, B12 deficiency anemia, elder age, hepatopathy, and after surgical stomach interventions. The next part of our lecture is drugs for peptic ulcer and gastroesophageal reflux disease. Peptic ulcer is a break in the inner lining of the stomach, first part of the small intestine, or sometimes the lower esophagus. The goals of anti-ulcer therapy are relief of pain, ulcer healing, prevention of complications, prevention of relapse. That is why approaches for the treatment of peptic ulcer are reduction of gastric acid secretion, neutralization of gastric acid, antacids, ulcer protectives, anti-Helicobacter pylori. First is reduction of gastric acid secretion. Pharmacological group H2 antihistamines. These are cimetidine 0.4 twice daily or 0.8 at bedtime, ranitidine 0.15 twice daily or 0.3 at bedtime, famotidine 0.02 twice daily or 0.04 at bedtime, and roxatidine 0.075 twice daily or 0.15 at bedtime. Bioavailability of H2 antihistamines is adequate, from 60 to 80% due to first-pass hepatic metabolism. Absorption is not interfered by presence of food in stomach. It crosses placenta and reaches milk, but penetration in brain is poor because of their hydrophilic nature. The elimination half-life is 2–3 hours. About 60% of dose is excreted unchanged in urine and bile, the rest as oxidized metabolites. H2 antihistamines have been forced out by proton pump inhibitors. Determined on animals that H2 antihistamines have side effect by blocking uterine relaxation and bronchial relaxation. H2 blockers potentiate histamine-induced bronchospasm. They attenuate fall in blood pressure due to histamine, especially the late phase response seen with high doses. Next group, proton pump inhibitors or hydrogen potassium ATPase inhibitors. Can totally stop hydrochloric acid secretion, both resting as well as that stimulated by food or any of the secretagogues without much effect on pepsin, intrinsic factor, juice volume, and gastric motility. Are inactive at neutral pH, but at pH less than 5, rearranges to two charged cationic forms that react with subhydryl groups of the hydrogen potassium ATPase enzyme and inactivate it irreversibly. Acid secretion resumes only when new hydrogen potassium ATPase molecules are synthesized. Drugs: omeprazole 0.02 once daily, esomeprazole 0.02 to 0.04 once daily, lansoprazole 0.015 to 0.03 once daily, pantoprazole 0.04 once daily, rabeprazole 0.02 once daily up to 0.06 daily, and dextrabeprazole 0.01 to 0.02 daily. Bioavailability is around 50% due to acid lability. Bioavailability is reduced by food. They should be taken in empty stomach, followed 1 hour later by meal to activate the hydrogen potassium ATPase and make it more susceptible to the drug. The plasma half-life is 1 hour, but inhibition of hydrochloric acid secretion occurs within 1 hour, reach maximum at 2 hours, and T50 is around 24 hours and effect lasts for 2-3 days. Secretion resumes gradually over 3-5 days after stopping the drug. Third group, anticholinergic drugs. Atropine-like drugs reduce the volume of gastric juice without raising its pH unless there is food in stomach to dilute the secreted acid. Stimulated gastric secretion is less completely inhibited. Effective dose for ulcer healing of non-selective antimuscarinic drugs, atropine, propanthelin, oxyphenonium, invariably produce intolerable side effects. Introduction of H2 antihistamines and proton pump inhibitors send them into oblivion. The drugs are pyrazipine or gastrozepine 0.1 to 0.15 daily oral, propanthelin and oxyphenonium, and drugs acting on autonomic ganglia, ganglioblockers, quaternary ammonium compounds, hexametonium, amines, secondary tertiary, mecamilamine, monosulfonium compound, trimetafan. Fourth group, prostaglandin analog. PGE2 and PGI1 are produced in gastric mucosa and appear to serve a protective role by inhibition acid secretion and promoting mucus as well as hydrocarbonate secretion. Prostaglandins inhibit gastrin release, increase mucosal blood flow. Prostaglandins are able to reinforce the mucous layer covering gastric and duodenal mucosa, which is buffered by hydrocarbonate secreted into this layer by the underlying epithelial cells. Natural prostaglandins have very short half-life. The drug is misoprostol, 200 micrograms 4 times a day. The primary indications for use is the prevention and treatment of non-steroidal anti-inflammatory drugs associated gastrointestinal injury and blood loss. So, all 4 groups before this were those which reduce gastric secretion. Now the next group, neutralization of gastric acid, antacids. They are subdivided into systemic and non-systemic. First group is systemic. They are the basic substances which neutralize gastric acid and raise pH of gastric contents. Peptic activity is indirectly reduced if the pH rises above 4. The potency of an antacid is generally expressed in terms of its acid neutralizing capacity, ANC. This is important because a single dose of any antacid taken in empty stomach acts for 30-60 minutes only, since in this time any gastric content is passed into duodenum. Taken with meals, antacid may act for at the most 2-4 hours. The drugs are sodium bicarbonate and sodium citrate. Side effects: large doses will induce alkalosis, produces CO2 in stomach, distension, discomfort, belching, risk of ulcer perforation, acid rebound occurs, increased sodium load, may worsen edema and chronic heart failure. Use is restricted to casual treatment of heartburn, provide quick symptomatic relief. The next, non-systemic antacids. These are insoluble and poorly absorbed basic compounds, react in stomach to form the corresponding chloride salt. The chloride salt again reacts with the intestinal bicarbonate so that hydrocarbonate is not spared for the absorption. No acid-base disturbance occurs. Small amount that are absorbed have the same alkalinizing effect as sodium hydrocarbonate. Drugs: magnesium hydroxide, magnesium trisilicate, aluminum hydroxide, magaldrate, aluminum hydroxide plus magnesium hydroxide, calcium carbonate, liberates CO2 in stomach. The role of antacid combinations: fast, magnesium hydroxide, and slow, aluminum hydroxide acting components. Magnesium salts are laxative, while aluminum salt are constipating. Gastric emptying is least affected, while aluminum tend to delay it, magnesium, calcium tend to hasten it. Dose of individual components is reduced. Systemic toxicity, depending on fractional absorption, is minimized. And in here you can see different trade names of antacid combinations. Third group is ulcer protectives. Sucralfate. Dosing 1.0 taken in empty stomach 1 hour before the 3 major meals and at bedtime for 4-8 weeks. It is a basic aluminum salt of sulfated sucrose, polymerizes at pH less than 4 by cross-linking of molecules, assuming a sticky gel-like consistency, which preferentially and strongly adheres to ulcer base, especially duodenal ulcer, and remains there for 6 hours. Surface proteins at ulcer base are precipitated, together with which it acts as a physical barrier preventing acid, pepsine, and if reflux is occur, bile from coming in contact with the ulcer base. Dietary proteins get deposited on this coat, forming another layer. Sucralfate, as it is, has no acid neutralizing action. Other ulcer protectives: colloidal bismuth subcitrate. Colloidal bismuth compound, water-soluble but precipitates at pH less than 5. It is not antacid but heals 60% ulcer at 4 weeks and about 80 to 90% in 8 weeks due to increased gastric mucosal prostaglandin E2, mucus, and hydrocarbonates production, precipitate mucus glycoproteins and coat the ulcer base, detach and inhibit Helicobacter pylori. The other trade name drugs, Denol and Trimo, to be taken 0.12, half hour before 3 major meals and at bedtime for 4-8 weeks. And fourth approach for the treatment of peptic ulcer is anti-Helicobacter pylori therapy. The drugs are amoxicillin, clarithromycin, metronidazole, tinidazole, and tetracycline. They will be discussed later in the lecture 15 in more details. And now I would like to stop on Maastricht Consensus anti-Helicobacter pylori therapy. The European Helicobacter Study Group first took the initiative in 1996 in Maastricht, Netherlands, to gather dedicated experts in the field and to review and discuss all relevant clinical data to arrive at recommendations for the clinical management of Helicobacter pylori infection. So, first line, triple therapy. Proton pump inhibitors, omeprazole, pantoprazole, lansoprazole, rabeprazole, esomeprazole, standard dose twice a day. And 2 of 3 antibacterial, amoxicillin 1.0 twice a day, clarithromycin 0.5 twice a day, metronidazole 0.5 twice a day. 7 days course. Second line, quadrotherapy, reserve if triple therapy is not effective. Proton pump inhibitors, standard dose twice a day. Bismuth subcitrate 0.12 4 times a day. Metronidazole 0.5 3 times a day. Tetracycline 0.5 4 times a day. 7 days course. And modifications in 2005. based on line 1 or line 2 therapy. First, metronidazole better than amoxicillin. Second, therapy duration is prolonged up to 14 days, increase effectivity plus 12%. And third, rescue therapy. Proton pump inhibitors plus amoxicillin up to 3.0 per day, duration 10-14 days. Proton pump inhibitors plus amoxicillin, rifabutin or levofloxacin, duration 7-10 days. And proton pump inhibitors plus bismuth subcitrate plus tetracycline plus furazolidone, duration 7 days. Standard triple therapy, effectivity 90 to 95%. Denol, bismuth subcitrate, 2 tablets 4 times a day. Tetracycline 0.25 to 0.5, 4 times a day, or the name oxacillin. Metronidazole 0.25, 3-4 times a day. Duration 2 weeks. And in here you can see principles of anti-Helicobacter pylori therapy in table form. The next part of our lecture is drugs that affect the excretory function of the pancreas. Classification. This group includes various drugs of origin that stimulate or replace the excretory function of the pancreas or inhibit it, suppress the activity of proteolytic enzymes. First, drugs that stimulate or substitute excretory activity of the pancreas. First, of animal origin, secretin, cholecystokinin, pancreatin, panzinorum forte, festal, hemicellulase, creon. Second, microbial origin, solisine. Third, obtained from mushrooms, orasa. And fourth, plant origin, dill seeds, peppermint leaves, hawthorn fruit, and others. Second, drugs that inhibit excretory activity of the pancreas, inhibitors of proteolytic enzymes. First, preparations of the pancreas, Gordox for example. Second, receipt from the tissue of the lungs, contrical or aprotenin and ingitril. And third, synthetic origin, aminocapronic acid. As an example, creon, indications for use. Insufficiency of exocrine pancreatic function in adults and children caused by cystic fibrosis, chronic pancreatitis, pancreatectomy, gastrectomy, pancreatic cancer, obstruction of the pancreatic or common bile duct, and other diseases. Contraindication: acute pancreatic inflammation in the early stages and hypersensitivity to pancreatin of pork origin or to any other component of the drug. Side effects: gastrointestinal disorders frequent, abdominal pain infrequent, constipation, changes in the nature of stool, diarrhea, nausea, and vomiting. Changes from the skin and subcutaneous tissue, uncommon, skin allergic reactions or hypersensitivity reactions may occur. Next one, festal. Contraindications: allergy to the components of the drug, severe liver damage with high levels of bilirubin, biliary obstruction, hepatic coma, intestinal obstruction. Side effects are not established. And contrical or aprotenin, an inhibitor of proteolytic enzymes, kallikrein, trypsin, chymotrypsin. In addition, it inhibits the activation of plasminogen and its transformation into fibrinolysin, as well as the activity of it. Aprotenin is well tolerated even in high doses. In cases of very rapid administration, possible nausea and vomiting, and rarely local irritation. After frequent repeated doses of the drug, thrombophlebitis might develop. Allergic reactions occur rarely. And on this and next slide, there is a treatment program of acute pancreatitis and chronic pancreatitis. I will leave these two slides for a few seconds for you to be able to pause them and take a look later. The next part of our lecture is emetic, antiemetic, prokinetic, and gallstone dissolving agents. In here you can see major central and visceral structures involved in emesis and the neurohumoral receptors mediating the emetic response. NTS, VC, CTZ, 5-HT3, H1, D2, M, NK1, and CB1. Vomiting. occurs due to stimulation of the emetic vomiting center situated in medulla oblongata. The chemoreceptor trigger zone located in the area postrema and the nucleus tractus solitarius are most important relay areas for afferent impulses arising in gastrointestinal tract, throat and other viscera. The chemoreceptor trigger zone is also accessible to blood-borne drugs, mediators, hormones, toxins, etc., because it is unprotected by the blood-brain barrier. Cytotoxic drugs, radiation, and other gastrointestinal irritants release 5-HT from enterochromaffin cells, which acts on 5-HT3 receptors present on the extrinsic primary afferent neurons of the enteric nervous system. These neurons connect with vagal and spinal visceral afferents to send impulses to nucleus tractus solitarius and chemoreceptor trigger zone. Released in large quantity, 5-HT may also spill into circulation and reach chemoreceptor trigger zone via vascular route. 5-HT may also be released from platelets by inflammatory mediators. 5-HT is not the only mediator of such signals. Some peptides, substance P, and other messengers are also involved. Emetics, drugs used to evoke vomiting. Classification of them. Those which act directly on chemoreceptor trigger zone apomorphine, and those which act reflexively and on chemoreceptor trigger zone ipecacuanha. Antiemetics, the drugs which prevent or suppress vomiting. Pharmacological groups: anticholinergics, hyoscine dicyclomine, H1 antihistamines, promethazine, diphenhydramine, dimenhydrinate, doxylamine, meclozine, cinnarizine. Neuroleptics D2 blockers, chlorpromazine, triflupromazine, prochlorperazine, haloperidol. Prokinetic drugs, metoclopramide, domperidone, cisapride, mosapride, etopride. 5-HT antagonists, ondansetron, granisetron, palonosetron, ramosetron. NK1 neurokinin receptor antagonists, aprepitant, fosaprepitant, and adjuvant antiemetics, dexamethasone, benzodiazepines, dronabinol, and nabilone. In here you can see schematic depiction of serotoninergic regulation of peristaltic reflex and sites of action of prokinetic drugs. And in here metoclopramide, alginate, antacid action. One more group is gallstone dissolving drugs. Cholesterol remains dissolved in bile with the help of bile salt, salt of folic acid and henodeoxycholic acid conjugated with glycine and taurine. A high cholesterol bile-salt ratio favors crystallization of cholesterol in bile. These crystals act as needle for stone formation. Henodeoxycholic acid, henodiol, and ursodeoxycholic acid, ursodilol, decrease cholesterol content of bile, enabling solubilization of cholesterol from stone surface. These two acids act differently. The next part of our lecture is drugs that stimulate the synthesis of bile. Classification. First, drugs that stimulate bile, choleretics. Mechanism of action: improve the formation of liver bile. These are the so-called true choleretic drugs. Choleretics by origin are divided into 4 subgroups. First, drugs containing bile or bile acids. Second, synthetic choleretics. Third, drugs of plant origin. And fourth, hydrocholeretics, drugs that increase the secretion of bile due to its water component. Second group, drugs that improve bile excretion. They are divided into 3 subgroups. First, cholekinetics, drugs that increase the tone of the gallbladder with the simultaneous inclusion of the reflex of the opening of the sphincter odi. Second, cholelytics, cholespasmolytics, drugs that help relax the tone of the biliary tract. And third, drugs of the combined modulatory action on bile secretion. Regulate the tone of the valves and improve the contractility of the gallbladder and duct. And third, drugs with combined action on bile formation and bile excretion, combining the properties of the first and second subgroups. In here you can see mainly trade names, for example, Holon, Dehelin, Suprahol, Leofil, Henofalk, Henolong, Henocin, Ursofalk, Ursohol, Ursosan, Bilagit, and Alcohol, but pay your main attention on the active component which is in brackets. General mechanism of action of choleretics. Increase of secretion of bile directly due to stimulation of secretory function of liver parenchyma. Increase of osmotic gradient between bile and blood, which causes osmotic filtration in bile ducts of water and electrolytes. Increase of bile flow through the bile ducts, which leads to preventing or reducing the inflammatory process and stagnation. Stimulating the receptors of the mucous membrane of the small intestine that reflexively enhances choler secretion. Indications for use. Choleretics are used in various diseases of the liver, biliary tract, chronic hepatitis, cholangitis, cholecystitis, cirrhosis of the liver, etc., mainly to improve the drainage of the biliary system. Due to the creation of a constant movement of bile, its stagnation in ducts is eliminated, absorption in the blood decreases, conditions for the development of infection and the formation of stones deteriorate, the intensity of the inflammatory processes decreases. Contraindications. Choleretic drugs are contraindicated in patients with hepatitis, acute and subacute liver dystrophy, with diseases that are accompanied by obstructive jaundice. Oxafenamide should not be prescribed to patients with cholelithiasis and cholecystitis with angina pectoris, increased cholecystitis and pain syndrome. Henodeoxycholic acid is contraindicated in cases of X-ray stones in the gallbladder, a non-functional gallbladder, frequent hepatic colic, chronic hepatitis and cirrhosis of the liver, inflammatory diseases of the small and large intestine, and others. Side effects. Side effects during choleretic therapy are rare. These drugs, like oxafenamide, in some patients cause diarrhea. Side effects of nicodine are a feeling of warmth or slight short-term pain in the epigastric region, mainly in stagnant forms of hepatitis. The next part of our lecture is hepatoprotectors. Hepatoprotectors are a pharmacotherapeutic group of drugs that prevent the destruction of cell membranes and stimulate the regeneration of hepatocytes, thereby exerting a positive effect on liver function. Classification of hepatoprotectors. Natural drugs or semi-synthetic. Drugs that contain natural or semi-synthetic flavonoids of plants. Drugs of animal origin. Drugs that contain essential phospholipids. Drugs of ursodeoxycholic acid. Drugs with components of hepatocellular metabolic cycles. Indications for use. Acute viral hepatitis, subacute and chronic hepatitis, toxic hepatitis including alcoholic cirrhosis of liver, liver damage with hepatotoxic substances, as well as the prevention of liver function disorders, for example in connection with surgical interventions on it, gallbladder, blood vessels, etc. Contraindications. Diabetes mellitus with concomitant cholestatic syndrome, as well as the emergence of severe decompensation of diabetes mellitus. And the last part of our lecture is drugs for constipation and diarrhea. Laxatives, aperients, purgatives, cathartics, these are the drugs that promote evacuation of bowels. A distinction between them is sometimes made according to the intensity of action. Laxative or aperient, milder action, elimination of soft but formed stools, and purgative or cathartic, stronger action, resulting more fluid evacuation. Many drugs in low doses act as laxative and in larger doses as purgative. And in here you can see type of stools and latency of action of purgatives employed in usually recommended doses. For example, soft formed feces take 1-3 days, bulk forming, docusates, liquid paraffin, lactulose. Semi-fluid stools take 6-8 hours, phenolphthalein, bisacodyl, sodium picosulfate, and senna, and watery evacuation within 1-3 hours, saline purgatives, and castor oil. Classification of them. Depending on the localization of the action, laxatives are classified by the increase of the motor function. A. Predominantly of the small intestine, castor oil, castor, olive, almond, sesame, as well as fish oil. B. Predominantly of the thick intestine, phenolphthalein or purgan and isophenine. And C. All parts of the intestines, sodium salts and magnesium sulfate, water-soluble phosphates, etc. Mechanism of action of them. Laxatives cause dilution of the contents of the intestines, increase their motor function, and accelerate defecation. The action of laxative drugs is reflexive, causing irritation of sensitive intestinal receptors. Increased motility in the place of action of laxatives reflexively extends to other parts of the intestines as well as to other organs, especially the cardiovascular system. There is a redistribution of blood flow, which leads to a decrease in blood flow to the vessels of the brain and to eliminate the threat of hemorrhage. Laxatives, especially potent ones, stimulate contractile function of the uterus, so they are prescribed with caution during pregnancy and menstruation. Indications for use. Laxatives containing antroglycosides as well as synthetic drugs are used primarily to eliminate the usual constipation, as well as in the case of delay and difficulty of bowel movements due to hemorrhoids. In such cases, these drugs are taken in large doses and in ineffective use of other laxatives. Contraindications. Acute diseases of the abdominal organs, appendicitis, cholecystitis, cystitis, peritonitis. The presence of mechanical obstruction to promote the contents of the intestines, strangulated hernia, ileus, diseases that are accompanied by bleeding from the uterus, digestive canal, etc. Side effects. In large doses can cause abdominal pain and tenseness. They should be used with caution in pregnant women as well as in patients with liver and kidney diseases. Negative reactions to laxatives prevent the careful selection of doses. And the last pharmacological group for today is antidiarrheal agents. Diarrhea is a symptom of many diseases and intoxications: dysentery, cholera, sometimes tuberculosis, septic processes, arsenic poisoning, heavy metal salts, etc. Often, its cause is an insufficient function of the stomach, ileia, and pancreas, and diseases of the endocrine glands. Mechanism of action with classification. There are 5 groups. Many of them we discussed in Lecture 3. First group, cytoprotectors. These are binding agents reacting with tissue proteins on the surface of the mucous membranes, erosions, and ulcers, form albuminates in the form of a film that covers the surface of the mucous membrane of the stomach and intestines. This film protects it from mechanical, thermal, and chemical irritations, resulting in a decrease in the flow of pathological impulses from the damaged zone, inhibiting the absorption of various substances, including toxic. As a result, the inflammatory reaction disappears in the injury zone, the motility of the intestines decreases, the epithelialization of erosions and ulcers is accelerated. We discussed these drugs today already in the previous parts of today's lecture and also in Lecture 3. Tunnel bean and other herbal preparations are used from the group of astringent drugs for the eradication of diarrhea, as well as the synthetic preparation bismuth nitrate basic. Second, herbal products, like antidiarrheal agents, infusions and decoctions of different plants and fruits are also used. Third, covering or enveloping agents. We also discussed them in Lecture 3. These are high molecular substances which form colloidal solutions with water, mechanically protect the mucous membrane of the digestive canal from irritation. As a result, reflex responses are reduced, intestinal motility is inhibited, absorption in the stomach and intestines, including drug and toxic substances, slows down. Favorable conditions are created to eliminate the inflammatory process. The covering or enveloping effect is made up of starch, tragacanth, Arabic gum, preparations made from almond root, saluba tubers, flax seeds, and others. Fourth group, adsorbents. Orally used adsorbent agents, in addition to anti-inflammatory action, contribute to lowering the acidity of gastric juice and inhibit gut motility, eliminate flatulence and diarrhea. The most effective adsorbent agent is activated charcoal. It has a large overall surface. 1 gram is about 200 square meters. It is available in the form of powder, granules, capsules, and tablets called carbolanum. Activated charcoal is used as an adsorbent in hyperacid gastritis, flatulence, infectious diseases of the digestive canal, food intoxication, poisoning with alkaloids, strychnine, morphine, atropine, etc., barbiturates, heavy metal salts, phosphorus, potassium, cyanide. And fifth, synthetic drugs. Synthetic antidiarrheals as loperamide hydrochloride, iodomium, lopedium, imodium, which reduces the tone and motor activity of smooth muscles of the intestines due to binding to the opiate receptors of their walls. Increases the tone of the sphincter. The action of the drug comes quickly and lasts for 6 hours. Indications of antidiarrheal agents. Acute and chronic diarrhea of different origins, regulation of excretion in patients with ileostomy. Side effects: headache, pain in the epigastric region, dry mouth, allergic reactions. Contraindications: pregnancy, lactation, age up to 2 years, acute ulcerative colitis, intestinal obstruction. These are the characteristics of loperamide. And the last part of our lecture is examples of MCQs. Omeprazole, an agent for the promotion of peptic ulcers treatment, has a mechanism of action that is based on. We discussed this today. It is easy. Of course, the answer is hydrogen potassium ATPase. Bismuth salts are thought to be effective in peptic ulcer disease because they have bactericidal properties against. In here it is also very easy. The answer is Helicobacter pylori. The approved indication for misoprostol is, as you remember, prostaglandin analog. We also discussed this today. The answer will be prevention of gastric ulceration in patients using large doses of aspirin-like drugs. The primary pharmacological action of omeprazole is the reduction of, this is also very easy, secretion of hydrochloric acid. A patient complains of stomach ache and heartburn. Tests revealed the increase of gastric juice acidity. What drug should be prescribed to the patient for neutralization of the excessive acidity of gastric juice? As you remember, neutralization of gastric acidity is antacids. In here, antacids, we have Almagel. Almagel we discussed in lecture 3. It is a kind of antacid. To a patient with ulcer disease of stomach was prescribed drug, the mechanism of which action is based on the blockade of H2 histamine receptors. Call this drug. This is also very easy. In here the answer will be famotidine. Metoclopramide has antiemetic properties because it is also very easy. You must simply remember what is the pharmacological group of metoclopramide. And the answer is a central nervous system dopamine receptor antagonist. A 37-year-old man was admitted to the surgical department with symptoms of acute pancreatitis, vomiting, diarrhea, bradycardia, hypotension, weakness, dehydration of the organism. What medicine should be used first of all? In here we are searching for an inhibitor of proteolytic enzymes, and it is aprocitenine or Contrical. Laxative drug having osmotic activity was prescribed to patient. What is this drug? Osmotic activity has got laxatives which are salts. As an example, in here it is magnesium sulfate. Thank you for the attention.